In this presentation, we focus on the quality of routine childbirth care in Gombe. I will outline the need for improvements in measurement to better capture the quality of services delivered and their impact on people's health and experience of care, and present findings from the clinical observations of births that have been completed in 10 primary healthcare clinics. These findings provide a detailed picture of the care that is being provided to women and their newborns in these facilities. Maternal and newborn health remains a key priority for the global health and development agenda. The majority of deaths are preventable through appropriate management of pregnancy and care at birth. The persistence of preventable maternal and newborn deaths has led to a renewed focus on quality of care. And globally, it's been estimated that a higher burden of mortality is attributable to poor quality of care than access to care. It can be seen in the picture that quality of care is a multi-dimensional concept. It has been defined in terms of structure, processes, and outcomes. Increasingly, definitions incorporate the needs, experiences, and preferences of people and their right to be treated with respect. Indicators that simply measure contact or access to care, for example, the proportion of women who had skilled birth attendants, do not capture this complexity. They provide no indication of the content or the quality of care delivered, and as such, they can lead to the health benefits of programs being overestimated. Advancements in measurement are needed to account for the quality of care delivered and their impact on people's health and experience of care. To help unpack the complexity, a health service coverage cascade has been proposed by Amuzu and Marsh. You will find the papers detailing their work in the additional resources accompanying this talk. The cascade outlines a series of steps that the target population is anticipated to have to move through in order to achieve the intended health benefit. In general, cascades start with clearly defining the target population, i.e. the number of people in need of a specific service. In the case of childbirth care, the target population is all pregnant women. The cascade then includes successive steps of the proportion in need who came into contact with the service, that is ready to deliver the service, for example, has the drugs, equipment, and adequate staffing in place, who receive appropriate and timely care, according to quality standards, which includes accounting for users' experience of care, where users adhere to the prescribed medication or instructions given by the care provider, and experience the expected health outcome. The content of each step of the cascade will look different depending on the service being provided. The cascade can be used to identify where bottlenecks in service provision may have occurred. Pictured is the ideal scenario, where everyone in the target population receives all steps of the cascade. In this second hypothetical example, we see the population is diminishing as we move along the cascade. In a bottleneck analysis, the relative size of the population lost at each step of the cascade is estimated to indicate where the most urgent action may be needed. Where gaps are identified, additional research may be required to investigate the reason for these gaps. So now in the picture, the largest gap is between the population in need and the population visiting a health service. This suggests there may be potential issues with access, availability, or acceptability of care, or a lack of awareness of the need to seek care. There is also a substantial gap between those making contact with the service and those making contact with a service that is ready to provide care. This may highlight potential supply issues. So we evaluated the quality of care provided during uncomplicated facility delivery in 10 primary care facilities in Gombe. Observations were completed every 6 months over a 2-year period. The analysis that I am about to present provides an in-depth examination of the care that is being provided during facility-based childbirth. So observations were completed in the 10 primary healthcare centres with the highest number of births. Observers use a standardised checklist, which is pictured, to record the processes of care and birth attendant-client interactions. Observations were completed over a 3-week period, and observers were constantly present in the labour room during that time. Observations were therefore conducted from whenever the woman was admitted to roughly 1 hour postpartum. Observers were required to prioritise women in the 2nd and 3rd stage of labour. To define the quality of care, we mapped indicators in the current WHO recommendations for high-quality maternal newborn care against the observation checklist. From this mapping, 50 measures were included, and these were grouped into 4 categories based on the stage of labour and delivery. The analysis was restricted to women who had an uncomplicated labour, which for the purposes of this study was defined as women who were sent to the ward to recuperate or were discharged home after birth and did not experience an adverse event or death. 4% of women who gave birth at the facility experienced major risks and complications whilst at the facility, including 6 severe preeclampsia or eclampsia and 6 twin deliveries. 3 women sadly died. For the 1,804 women that had an uncomplicated delivery, we calculated the percentage of women that received each of the 50 measures, adjusted for clustering by primary healthcare facility and stratified by time point. The graph presents an example of measures for each of the 4 stages of birth along the x-axis, and the y-axis indicates the proportion of women or newborns that received that particular measure. It can be seen that there was considerable variation between the different components of care. First, for those interventions that were done well, it can be seen that implementation was highest for clinical interventions. For example, in the 2nd and 3rd stage of labour, there was almost universal implementation of administering a prophylactic uterotonic and assessing for perineal and vaginal lacerations. In the immediate newborn period, there was high implementation of thermal care, clean cord care, and application of chlorhexidine to the cord. Turning now to what wasn't done so well, we see poor implementation of measures related to risk assessment. So during history taking and initial assessment, this included measuring temperature, asking about complications during current and previous pregnancies, measuring blood pressure, and checking the fetal heart rate. In the postpartum period, this included taking the temperature and checking the mother's vital signs within 15 minutes of birth. Findings indicate that while some essential processes of childbirth care were performed for almost all women and newborns, the proportion of women who consistently received evidence-based care during uncomplicated labour was low. There was substantial variation in the implementation of recommended evidence-based interventions, both within and across the different stages of childbirth. Implementation was highest for clinical interventions at the time of birth that have received international attention, for example, the provision of uterotonic, thermal and clean cord care. Implementation was lowest for measures designed as risk assessment, for example, history taking or the checking of vital signs. A manuscript is currently under review at BMJ Open and will be made available once it has been accepted. So the analysis I have presented provides a detailed picture of the services that women are receiving and whether they are receiving care according to standards. The next step is to move towards a population level estimate by combining this information with data on those who access care from the household survey and information on the readiness of those facilities to provide high quality care based on information in the facility survey. This work is ongoing and will be shared once completed. So to summarise, quality of care is a multidimensional concept. It can include the items that are available in health facilities, the availability of health staff, as well as the behaviours and capabilities of those staff. Adjusting for measures of quality is important because it can reveal the extent to which health services can achieve their potential for health improvement. Observations in 10 high-volume facilities in Gombe indicate that while some essential processes of childbirth care were performed for almost all women and newborns, the proportion of women who consistently received evidence-based care during uncomplicated labour was low. In particular, few benefited from basic risk assessments, leading to missed opportunities to identify risks and consequently late referrals and deaths. Work is ongoing to develop population-based estimate of quality of care in Gombe. We would like to thank the agency and implementing partners, our funder, and the many people in Gombe who gave generously of their time and made important contributions to this work. We also gratefully acknowledge our measurement partners, data research and mapping consultant. Thank you.